Hi, everyone. On today's podcast, we're going to talk about the evidence on saline locks during labor. Hi, everyone. Today, I wanted to bring some research evidence to you and talk a little bit about the evidence for saline locks. This is a topic that I first tackled 7 years ago at the Evidence-Based Birth blog, and I had to actually look it up. I could not believe it's been 7 years since I wrote a blog article about the evidence on saline locks. But to be honest, the reason why I didn't update the article in 7 years is because there was no research to write about. But today I'm excited to let you know that there is some new research. There's one new study on this topic, and I want to give you an overview of the evidence on saline locks. A saline lock is sometimes called a hep-lock for historic reasons, which I'll explain in a minute. But a saline lock is an intravenous or IV catheter that is threaded into peripheral vein, flushed with saline, and then capped off for later use. Before I go any further, I want to clarify a misconception that a lot of people have who are not workers in the healthcare field. A lot of times people think that there is a needle permanently in your vein. But in fact, the needle is used to place a tiny little catheter, which you might describe as a tiny little straw or plastic tube, into your vein, and then the needle is retracted and thrown away. So there is no needle in your arm. It's just tiny little catheter or straw that is threaded into your peripheral vein, flushed with saline, and then capped off for later use. That's why they call it a lock, because it's kind of locked off so that it won't leak. A saline lock used to be called a heparin lock or hep-lock because it used to be flushed with heparin, a blood thinner, and the thought was that the heparin would keep it from clotting off or getting blocked with a blood clot. Unfortunately, this led to catastrophic medical mistakes in which too high doses of blood thinners were accidentally put into people's veins. Eventually, randomized trials showed that saline or salt water is effective for flushing the saline locks, and thus the change in name from hep-lock to saline lock. Although the name hep-lock continues to stick around today, and you still hear some people say that, locks are always flushed with saline, not heparin. Now, with a saline lock, you are not hooked up to tubing or tethered to an IV pole, but hospital staff have easy access to your vein in case they need to inject something into your vein later, like medications or fluids. So why might a saline lock be used during labor and birth? Interestingly, most people giving birth at home or freestanding birth centers do not have saline locks. While in hospitals, most people either have an IV hooked up to fluids or a saline lock, quote, just in case. Saline locks can serve a useful purpose. They can be easily accessed to administer IV pain medications, anti-nausea drugs, or antibiotics. For example, if you have Group B strep or if you have an infection. The saline lock can also be hooked up to give you IV fluids. So it might be locked off and then you need IV fluids, so they connect it to tubing and can give you fluids through that tubing. This might be done if you're feeling nauseated or if you're exhausted and feeling really tired. Sometimes the IV fluids can be done to give you a bit of a boost. If you end up needing Pitocin or synthetic oxytocin to augment or strengthen your labor, then Pitocin has to be given through an IV infusion. And so a saline lock could also be used for that. It could be hooked up to tubing and an IV pump or pole to continuously deliver the Pitocin through your IV. If you request an epidural, you'll automatically get a saline lock as well. And often that saline lock will just go ahead and be unlocked and hooked up to tubing and fluids. Epidurals and spinals are higher risk interventions, and IV access is needed in case something goes wrong. Some hospitals also typically administer extra IV fluids through the IV to help with the low blood pressure side effect that happens with epidurals. A saline lock can also be used commonly after birth to infuse a bag of fluids containing Pitocin or synthetic oxytocin. However, Pitocin can also be easily delivered after the birth through a one-time injection in the muscle. We're going to be talking more about Pitocin during the third stage of labor after your baby is born in an upcoming EBB article in 2020. A saline lock could also be accessed quickly or would already be in place if someone needed emergency surgery. Finally, a saline lock could be accessed if you have excess bleeding after the birth, also known as postpartum hemorrhage. When postpartum hemorrhage, or PPH, occurs in the first 24 hours after birth, it's sometimes called primary PPH or early PPH. Nurses can give IV fluids and rarely blood products to restore the body's fluid and blood volume if someone loses too much blood after birth. Importantly, the American College of Obstetricians and Gynecologists, or ACOG, recently updated their definition of postpartum hemorrhage to be either blood loss of 1,000 milliliters of more, or blood loss accompanied by signs and symptoms of low blood volume within 24 hours following birth. Signs and symptoms of low blood volume include fast heartbeat, low blood pressure, fast breathing, low urine output, unhealthy paleness, dizziness, or an altered mental state. So what are the chances of someone getting postpartum hemorrhage? Well, estimates of the risk vary widely depending on which definition for postpartum hemorrhage is used. Randomized controlled trials have found that rates of blood loss greater than 1,000 milliliters range from 0.9% to 2.9% when routine medications to prevent postpartum hemorrhage are given in the third stage, versus 2.4% to 4.8% when routine medications are not given in the third stage to prevent postpartum hemorrhage. And like I said, we'll be talking more about those medications and postpartum hemorrhage in an upcoming article. Now, the percentage of people who require blood transfusion or blood products for hemorrhage is even smaller. In one study, they found that only 0.26% of women who labor and give birth will need a blood transfusion for hemorrhage. This translates to about 26 people out of 10,000. Now, some people are at a higher risk for early postpartum hemorrhage than others, and many of these risk factors can be identified before you go into labor. Risk factors for postpartum hemorrhage that can be identified before you have your baby include having a history of prior cesarean, having placenta problems, having high blood pressure, a history of postpartum hemorrhage, having given birth 5 times or more before this pregnancy, being a first-time mother, being pregnant with multiples, giving birth at 42 weeks or later, or giving birth preterm before 37 weeks, having a medical labor induction, being 35 years old or greater, and having a cesarean. There are a few important risk factors for postpartum hemorrhage that cannot be identified until after you give birth. And these include having a retained placenta, where pieces of the placenta are retained in your uterus, having a tear in the cervix, or experiencing a uterine rupture. We're going to go into more detail about postpartum hemorrhage, the risk factors, and how it can be prevented or treated in a different podcast episode and blog article we'll be publishing in 2020. In many of the situations I discussed above, like if you need an epidural or you need blood products or fluids, it's clear that an IV is medically necessary. And if you have risk factors for postpartum hemorrhage, that may also tip the balance into favoring a routine IV placement when you get to the hospital in labor. But what about someone who desires an unmedicated birth and wants to avoid having an IV? And what if they are at low risk for postpartum hemorrhage? Why might some people want to avoid having a saline lock? Are there any drawbacks? Well, it can be painful to have an IV placed, and some women find it uncomfortable and distracting during labor. It can cause a little bit of bruising or a small amount of bleeding at the site. Eventually, the vein can become inflamed. This is called phlebitis, which can cause redness and pain. This happens in about 1 in 10 IVs. If the IV is used for medication or fluids, these may leak out of the vein and into the tissues. This is also known as extravasation, and the risk of this happening is about 1 in 3. Having a saline lock might make it easier for hospital staff to initiate interventions that you don't want and you said you didn't want on your birth plan. For example, if you didn't want IV fluids or Pitocin for augmentation. And then finally, the saline lock can sometimes be viewed as a symbol that you are sick and a patient instead of a healthy person giving birth. This symbol might have negative consequences for your mindset and may also affect people's attitudes towards you during labor. In my work at Evidence-Based Birth and teaching childbirth classes, I found a mixture of parents that I work with. Some who really don't care whether or not they have a saline lock. Some people know that they want a saline lock, because they're planning on getting an epidural or they think they might get an epidural. And some who definitely do not want a saline lock because they feel it's unnecessary, or perhaps they have a fear of needles and they just don't want that added distraction if they're attempting an unmedicated birth. What I often see happening, especially in the United States, is that a saline lock is sometimes seen as a, quote, compromise between having an OB who's used to administering lots of interventions during labor and wants that IV access, and the parent who wants an unmedicated birth. An OB might say to a patient, "You don't have to be hooked up to IV tubing with fluids and medications, but I require all my patients to have a saline lock just in case." But what's the evidence on that? What's the evidence on having a saline lock in someone who wants an unmedicated birth or who wants to avoid medical interventions as much as possible? What's the evidence on having a saline lock, quote, just in case? The surprising thing is, even though having a saline lock just in case is routine at hospitals all across the US and in other places around the world, there has never been a single randomized controlled trial on this topic. Nobody has ever done a study and randomly assigned some birthing people to have a saline lock and some people to go without one until they need one, or go without one entirely as long as they don't need one. In fact, there's only ever been one study published on this topic, and it just came out in 2019. I was so excited to see this study topic listed in the Journal of Midwifery and Women's Health. This is one of my favorite medical or research journals to read. The article is called Timing and Outcomes of an Indication-Only Use of Intravenous Cannulation During Spontaneous Labor. And the authors include Dr. Bailey, a certified nurse midwife with their PhD, Dr. Bell, an MD, and Dr. Zelensky, a certified nurse midwife with their PhD. This study took place at the University of Michigan, where there is a robust nurse midwifery program. And they have a policy there that saline locks are not required. Instead, saline locks are used as needed, not as a routine, quote, everyone gets one. I have to say, I loved this research article. It was so fascinating. One of the things I learned right away from reading the background section that I wasn't aware of before is that use of IV access during labor became routine during the era of twilight sleep in the early to mid 1900s. I covered twilight sleep in Evidence-Based Birth Podcast episode 75 when I interviewed my mom, Carol, who's a mother of 6, and had twilight sleep with her first 2 children in the 1960s. Basically, twilight sleep was an intervention received by most people who gave birth in the hospital for decades. In this procedure, women were sedated during labor, and then they had a gas mask used on them during the vaginal birth. So they had general anesthesia, or they were knocked out unconscious during the actual delivery. They also had an episiotomy cut, and the baby was pulled out with forceps, and then women were separated from their babies and only allowed brief scheduled visits once a day. Women were also not allowed to eat and drink during labor, not even during early labor, and they were given IV fluids and medications through the IV while they were sedated. Now, most of these practices are not used anymore. Certainly, birthing people are not given medications to knock them out during a vaginal birth. But the authors of this research paper point out that even though twilight sleep and most of its practices has disappeared, the IV has remained part of routine practice in hospitals, along with not allowing women to eat and drink during labor, which we cover in our article, evidencebasedbirth.com/eating. Something else that I hadn't realized, but the authors pointed out, is that professional guidelines for postpartum hemorrhage prevention do not mention placing an IV on every laboring person. So in this study by Bailey et al. At their hospital, the University of Michigan, the certified nurse midwives were using something called an indication-based approach to IV use, meaning they only placed an IV if there was a reason to have one. And they wanted to conduct this study to describe the outcomes in their practice using this approach. So this was an observational study. They were simply looking at what was happening. It was also a retrospective study, meaning that they looked backwards in time at their medical records and their quality control records to examine outcomes. Just a little bit more background about this C&M practice. They attend about 700 births per year in the hospital, and their labor induction rate is only 22%, which in my opinion is pretty low for a hospital-based certified nurse midwife practice, and their cesarean rate is only 17%. In this study, they looked at people who gave birth in 2015 to 2016 and arrived at the hospital in spontaneous labor, so none of these birthers were having a labor induction. They excluded people with complications such as gestational diabetes, hypertension, and anyone who was not a candidate for a vaginal birth. For example, they did not include people with placenta previa or placental abruption. They only included people who were at least 34 weeks pregnant with a single baby in head-first position. In their practice, they recommended their clients get an IV if there was a reason for getting one, such as having a history of postpartum hemorrhage or a history of prior cesarean and going for a VBAC. If one of their clients refuses an IV, even though there's a medical reason to have one, the midwives use ongoing discussion, risk assessment, and shared decision-making, but they respect the client's autonomous choice. Another thing that's important to know about this practice is that they do give oxytocin or pitocin as a shot in the muscle after the birth. This is for postpartum hemorrhage prevention, and again, we'll be covering that intervention later in 2020, an article all about that topic. The midwife said that if someone declines the shot for postpartum hemorrhage prevention, that is noted in the chart. They visually estimated the blood loss after the birth, and they also recorded complete blood counts before birth for everyone, and also after the birth for anyone who had a postpartum hemorrhage. When they were looking back at the records, they divided the people in the study into 3 groups. The first group included people who had an IV placed when they were admitted in labor. The second group included people who had an IV placed later in labor or during postpartum. And the third group was made up of people who did not have an IV at all during labor or postpartum. If someone had an IV placed, the midwives documented the medical reason for the IV. The final sample was made up of 1,069 women in spontaneous labor. The average gestational age was 40 weeks, and about 42% of the participants had an epidural or spinal. The cesarean rate was only 7.5%. About 1 in 4 women, or 28%, had intermittent auscultation only and were not hooked up to an electronic fetal monitor. And the rest had some or continuous electronic fetal monitoring. Only 5 babies out of the entire sample had a low APGAR score at 5 minutes of life. Out of this low-risk sample, 42% had an IV placed on admission, 30% had one placed later in labor or during postpartum, and 28% never had an IV at all. The most common reason for having an IV placed on admission was antibiotics for group B strep. About 62% of the people in the immediate IV group were positive for GBS. The other reasons for having an IV placed on admission included a history of prior cesarean or a history of postpartum hemorrhage and having a spinal or epidural. For the people who did not have an IV on admission but had one placed later, 73% of them had an epidural or spinal, which was the main reason they ended up having an IV. The researchers stated that there were 0 cases where someone needed an IV urgently placed during labor. So all of the IVs placed during labor were non-urgent, with most of the IVs being placed so that the person could have an epidural or spinal. During the postpartum period, 36 people ended up having an IV placed, and 27 of those 36 placements were urgent. Urgent placements made up 8% of all IV indications in the study. Out of those 27 urgent IV placements, 25 of them were for a postpartum hemorrhage and 2 were related to fainting that was not caused by a postpartum hemorrhage. Now, when they looked at postpartum IV placements and outcomes, for this part of the study, they were only looking at the data from the 989 people who had a vaginal birth, and they excluded people who had a cesarean. Overall, in the entire study, 108 participants were diagnosed as having a postpartum hemorrhage after a vaginal birth. Most of them already had an IV placed, 70 of the 108. And 38 did not have an IV when they started having a postpartum hemorrhage. One of the interesting things about this study, you may be wondering why the postpartum hemorrhage rate was so high. This is because this study was done before ACOG changed their definition of a postpartum hemorrhage. So in this study, they used the definition of a blood loss of 500 milliliters or more, which is equivalent to a routine blood donation. In 2017, ACOG switched the cutoff for diagnosing postpartum hemorrhage to 1,000 milliliters or more, or signs and symptoms of low blood volume. Many of the people in this study who were diagnosed with a postpartum hemorrhage might not have met the criteria for a postpartum hemorrhage under the current definition. The authors state that only 32 women in the entire study had a blood loss of 1,000 milliliters or more. That means that only about 3.2% of people who had a vaginal birth in this study had a postpartum hemorrhage loss of 1,000 milliliters or greater. In this study, the most common treatment for people who had a postpartum hemorrhage was a medication called misoprostol that was administered in the rectum. And then the second most common treatment for postpartum hemorrhage was an intramuscular shot of methergin. In terms of blood transfusions, 7 women in the entire study needed a transfusion. 6 of these women had an IV placed on admission, so they already had an IV, and only 1 of those had an urgent IV placed for postpartum hemorrhage. Another interesting about this study is that some people declined an IV even though they were told they were experiencing a postpartum hemorrhage. Of the 38 people who did not have an IV when they were diagnosed with a postpartum hemorrhage, 15 refused an IV even though it was recommended to them. But only 1 of those 15 women had lost 1,000 milliliters of blood or greater. Also, none of these 15 people required blood transfusion or additional procedures in the operating room to control the hemorrhage. Next, the researchers also compared the hemoglobin counts. This is looking at anemia. So they looked at the admission hemoglobin counts and compared it to the postpartum hemoglobin counts in those people who had a postpartum hemorrhage. They found that although there was a decline in the hemoglobin levels after a postpartum hemorrhage, which is to be expected, there was no difference in the amount of decline between the 3 groups: those who had an IV already placed on admission, those who had an IV placed urgently for a postpartum hemorrhage, and those who did not have an IV and declined one when they had a postpartum hemorrhage. So in summary, in this observational retrospective study, they found that with a policy of only placing an IV when there's an indication, 28% of the low-risk people in their nurse midwifery practice never needed an IV. The most common reason for having an IV placed on admission was for group B strep antibiotics, and the most common reason for having one placed during labor was to get an epidural. For those who had a postpartum hemorrhage, hemoglobin declines were similar among those who had an IV placed on admission, those who had one placed urgently, and those who refused an IV altogether. Also, the majority of people who had a severe postpartum hemorrhage already had an IV placed when it happened, suggesting that the nurse midwives were doing a good job of identifying who was at higher risk for postpartum hemorrhage and could benefit from having an IV. The authors of this paper stated that for low-risk clients who are in spontaneous labor and not being induced, it's not necessary to have a mandatory IV policy, and that it's reasonable to establish IV access only when there's a medical reason to do so. Of course, this was a retrospective observational study, so we really need more information to understand the true benefits and risks of routine saline lock use versus only administering a saline lock when it's medically necessary. This study was also done in a high-resource facility in an academic medical center, and the results might not apply to smaller facilities that don't have as many resources. So to summarize, the benefits of having a saline lock include the ability to have additional fluids administered, the fact that it's needed in order to have an epidural. If you have a postpartum hemorrhage, the IV can be used for fluids and rarely blood products. It can be used to administer fluids to help with nausea or exhaustion. And if you do think you're going to need pain medications or fluids, it's nice to have a saline lock placed earlier in labor when you're more comfortable so that you can easily and quickly get IV medications or fluids later on when sitting still for an IV might be more difficult. The risks include the pain and discomfort of having the IV and that it can be distracting. It can cause bruising, phlebitis. And if fluids are administered, there is a risk that the IV might go bad and the fluids might leak into the tissues. In the end, I think it comes down to this. There is very little research on the topic of having saline locks during labor, just in case. In fact, there's only one study so far. However, there are both risks and benefits to having IV access. The ultimate decision for whether or not to have a saline lock should come from the birthing person. If they want one and feel safer or more comfortable by having a saline lock in case it's needed for medications or IV fluids, then that's their right to make that choice. If they've reviewed the risks and benefits and feel that they do not want a saline lock at that time, then that is also their right to make that choice. I also meet some parents who are birthing in highly medicalized settings who choose to get a saline lock as a sort of compromise and focus their energies on other choices on their birth plans. And then I also meet parents who do not want to compromise on this. For whatever reason or not, they've decided they do not want a saline lock, even though it is routine or sometimes even presented as mandatory. In the end, I hope that this episode was helpful or useful for you. You can find some of the references for what I talked about here for the original article at evidencebasedbirth.com/saline lock. If you want to learn more about IV fluids, we have an article at evidencebasedbirth.com/IV fluids. And we also talk in depth about group B strep at evidencebasedbirth.com/group B strep. Thanks everyone, and I hope you found this helpful. I'll see you next week. Bye.